Good morning, good evening, good afternoon, everyone, and welcome to the fourth day of the Micronutrients Forum Connected conference. We are so excited to have you here with us today, and we've seen pictures from you watching our live sessions even at 4 a.m. in the morning. So that's some dedication there, and we're really pleased to see all the lively discussions and the engagement that this week has brought us. Now we have 2 more days to go, and these are 2 very packed days with interesting sessions. And today we will start with a session on reducing the global burden of anemia and to discuss in particular what's the role for nutrition there. This will be followed by a session at 8:30 a.m. Eastern Standard Time where we will discuss infant and young child feeding and micronutrient powder programs, discuss challenges and lessons learned there and opportunities. We will then move on to a session discussing that a cost analysis is essential before considering scaling up micronutrient interventions. And then a session on supporting country-led policy discussions to implement multiple micronutrient supplementation during antenatal care. And this day will end with a session on hot trials. These are new trials, not yet published, that will share their results with you. So we hope you will enjoy this day as well. A couple of further comments. Please do visit our website and go and watch the poster sessions. We have 350 poster submissions, and we will announce tomorrow the 10 poster award winners of this year's conference. We also have the recordings of the live sessions of day 1 and 2 available now for you to watch on our website. And do visit our sponsor booths and our sponsored sessions, because there's a couple of very, very interesting sessions there that may spark your interest. And do follow us on social media, or do share your thoughts and your comments on the conference with us using the hashtag MNF2020. And with this, I would like to open this day with and hand over to the chair of this session, Angela da Silva. Thank you.
Hello, and good morning, good afternoon, and good evening, everyone. Welcome to the first session of today, which is on reducing the global burden of anemia. What is the role of nutrition? I'm Angela De Silva, Regional Advisor, World Health Organization Regional Office for Nutrition at WHO CRO based in New Delhi. In the session today, we have 3 very interesting presentations which provide updates ranging from those on 2 large-scale trials, one from Kenya and one from Bangladesh, which cover malaria and anemia, and the other on the effects of interventions of iron intervention in settings of high prevalence of anemia. And we also have a 3rd presentation on the biology of anemia and thalassemia. Now, before we start this presentations, I would like to just inform you all that there will be, the 3 presentations will last 20 minutes each, and we will be taking questions at the end of the session. So please do keep your questions coming into the chat box. We will try and make sure that we answer all questions, but in case there are questions that we are not able to answer, you can connect with the speakers through the connect function in the website. Please keep your questions brief and specific, and also try and mention whom you would like to direct the question to. So without any further time, I will introduce our first speaker for the day, and that is Professor Sarah Atkinson. Sarah is an associate professor in pediatric infectious disease, Department of Pediatrics at the University of Oxford and at Cambridge Wellcome Trust research program in Kilifi, Kenya. She works on interactions between nutrients such as iron, vitamin D, and infection. In today's talk, she will share with us exciting new results from a study investigating malaria gene interaction and red cells causing iron deficiency anemia in children in Kenya. Over to you, Sarah. Thank you.
Distributed across the world. Yeah.
I can hear you.
I can hear you too. Sarah's on the screen.
Looks like she's frozen.
Sure. Okay.
Do you want? Yeah, I can start.
Okay. All right. Yeah.
Do you want me to share my screen?
Do you want to, shall I start speaking? So I'm sorry, there's a small technical issue with Sarah. So we will get on to the next presentation and Sarah will come on later. So our next presenter for this session is Dr. Sandrine Pastrika, whom all of you may know pretty well. Dr. Sandra Pastrika is the division head at Walter and Eliza Reid Institute of Medical Research in Melbourne, Australia. His expertise, he's a clinical hematologist, epidemiologist, and a basic scientist who works in basic and translational aspects of iron biology. He runs several clinical trials on anemia control. In the next 20 minutes, Santa will share with us some of the new results from a major RCT on anemia control in young children, on iron supplementation in young children. Over to you, Santa.
Well, thank you very much, Angela, and good morning, everybody. I guess you can see the colourful background before me. That's behind me. That's because in Australia, this is NAIDOC week, which is the week that we celebrate the First Nations people, the Aboriginal people in Australia. So we traditionally just acknowledge that we're, at least here in Melbourne, I'm on Wurundjeri land, and I acknowledge the elders past, present and emerging and their leaders who've looked after the land for thousands of years. And also to, I guess, we're all over the world, and to just acknowledge the First Nations people of wherever you are today. I'm really excited to be able to present the results of this trial today at the Micronutrient Forum. When this session was first being planned, the Micronutrient Forum was obviously planned for, I think, March or February or who knows, it was so long ago, and this trial would not have been available for me to share. But obviously, the only benefit of the coronavirus is that actually we managed to finish the trial and finalize all the data, and the trial is now unblinded. So I'm now able to share these results with you, which is really very exciting. Before I start, I just want to acknowledge the enormous team who've worked on this project over the last 3 or 4 years or longer, particularly the team at the International Centre for Diarrheal Diseases Research, particularly Dr. Jenna Hamadani and Dr. Imrul Hassan, my mentors here in Melbourne, Dr. Bev Biggs, and the trial statistician, Sabine Abrat, and Layla Larson, who a lot of you might know, who worked with us for several years on this program. And beyond that, as those of you who've worked in field trials know, there's just an enormous team of people who worked in the field, collected samples, looked after the children on trials. So I want to start by thanking them, because really without them, there would be no talk today. So anemia, I guess I'm now the first talk. So I'll just remind you all that anemia is a state in which there isn't enough hemoglobin circulating to carry oxygen around to the tissues, and it's defined when hemoglobin falls between a particular threshold. And the group of people who have the highest prevalence of anemia are young children. And as many of you would know, that this burden of anemia really sits in South Asia, in Southeast Asia, and in parts of sub-Saharan Africa, where the prevalence of anemia in young kids it commonly exceeds 50%, and sometimes is much higher than that. And iron deficiency is an important cause of anemia. It's thought to, there's always been a hand-wavy thought that it accounts for about 50% of anemia, and WHO did some modeling. And in children, it looks like it's probably, they've estimated somewhere between about 30 and 50% of the contribution of the overall burden of anemia, depending on which part of the world that you're in. And how the key solutions to anemia in young kids has really focused on two ways of delivering iron supplements and home fortification with iron-containing multiple micronutrient powders. So we all know and love these interventions by now. So iron supplements can be given as iron drops, or probably not to a kid, iron tablets, and they're cheap. In fact, they're approaching free in some parts of the world. They're pretty easy to make, but of course the challenge is to be able to deliver them to a young baby. And the WHO recommends delivery of iron in populations where the prevalence of anemia exceeds 40%. So in children 6 to 23 months of age, so these really young kids, WHO says to give iron to basically every child in the population if the prevalence of anemia is above 40%, 3 months consecutively in the year. And the other important way that we deliver iron is, of course, through multiple micronutrient powders, which are iron that is contained in a form that allows it to be sprinkled onto complementary foods and doesn't contaminate or make the food inedible. And this has been a rapidly expanding way of delivering iron. And the WHO have also recommended that where the prevalence of anemia is above 20%, we do give multiple micronutrient powders as a possible solution to kids 6 to 23 months of age. And the benefit of micronutrient powders is you can also put in other micronutrients. So vitamin A, zinc, and many other micronutrients are often included in the sachets. Micronutrient powders have really expanded over the last decade, and just over the last few years, we've seen a big increase in their delivery. So about 18 million children were receiving MNPs in 2018. Though there have obviously been concerns about the safety of these interventions, particularly around infection. And I'll just point out some of the big trials in particularly non-malaria endemic areas. So this trial from Zulfi Bhutta's group and Sajid Sufi looked at the effects of MNPs with or without zinc. And they concerningly found an increase in the risk of days with diarrhea, which was increased by 15 to 30%. In this trial, this was a fantastically conducted trial, but one of the limitations was it didn't include a placebo. And so there's obviously the risk of a bias in the way that the parents were reporting their findings. But the effect of iron on diarrhea is supported by, for example, the fantastic studies by Michael Zimmerman's group, which do suggest that in areas where there's high pathogen carriage, iron interventions can actually promote the carriage of pathogens and reduce the carriage of commensal species. And these studies have been shown a couple of times, particularly in sub-Saharan Africa. So with those risks in mind, when I was helping undertake the systematic reviews to look at the efficacy and what are the real benefits of iron interventions, we were expecting that the data on the effects of iron on child development would be pretty secure. After all, that is one of the key rationales for the delivery of iron interventions and the alleviation of the burden of anemia. But when we looked, we found two things on these systematic reviews. The first was that there wasn't clear evidence of a systematic of benefit on say cognitive development or motor development from iron interventions on child development. But moreover, actually the number of kids included in these studies was pretty small. So I don't think there was actually the ability to conclude whether or not iron had actually advantages on functional outcomes. Nor was there really any data on the medium or longer term effects on child development. So we were left with a situation where really we had to consider the potential benefits and the potential risks of these iron interventions. And particularly the potential benefits would be on outcomes such as child development and child growth, and the risks being on infection. And you might see that I haven't included anemia as one of these outcomes, because I think as we move forwards, what we really need to consider is not just the effects on anemia. Anemia, a child and a mother aren't so worried about the number. They want to know that their baby is going to have a benefit or is experiencing a risk associated with the condition. And really, that's the way the whole world is moving in terms of guidelines and public health interventions and clinical interventions. You need to have a patient-centric outcome and rationale for your intervention. And so we really recognized that there was really very limited evidence for child developmental outcomes and indeed other functional health outcomes, yet there was growing evidence of risk. And so the key question was, is it actually worth giving the iron in the first place? And if it is worth giving the iron, now that we actually have two ways to deliver the iron, which system of iron delivery, iron supplements or MMPs, is the best one to pick? Indeed, these research gaps were identified in the WHO guidelines themselves. So the MNPs guideline identified a clear need for ongoing short and long-term functional, developmental, and adverse outcomes from the use of MNPs or multiple micronutrient powders. And there was also a need for and the iron supplementation guideline identified a need for additional long-term studies on functional outcomes, for example, cognitive and motor development. So we aimed to define the benefits and harms of daily iron supplementation and micronutrient powders in young children to enable evidence-based recommendations for implementation or withdrawal of these interventions in this age group. So we designed the benefits and risks of iron interventions, or BRISC trial, and this was meant to be the phase 3 efficacy trial of universal iron interventions in young children. This was an individually randomized, double-dummy, placebo-controlled randomized trial. The aims were to establish the functional benefits of iron supplements and micronutrient powders compared with placebos. and look at both the immediate effects of these interventions and evidence for sustained effects for these interventions. We also want to define the safety of these interventions compared with placebo and to compare between the two interventions. And finally, we wanted to be able to undertake a subgroup analysis to determine if there were differential effects, for example, if a child had baseline anemia, iron deficiency, or iron deficiency anemia at baseline. So this is the design of the trial. We recruited 3,300 children. It was a large trial, 1,100 children in each of the 3 arms. The children were 8 months of age, plus or minus 2 weeks at baseline. And at baseline, they underwent detailed child developmental testing, which I'll describe in a moment, as well as blood collection and anthropometry. They then received 3 months of intervention with either intervention or placebo. At the end of that 3-month period, they then received they then underwent repeat testing for child developmental studies and blood testing, as well as anthropometry and a whole lot of other, a battery of tests to assess functional impact. We then continued to follow the kids up for a further 9 months, so that the kids were on trial for a total of a year, off intervention for this last 9 months, and then we repeated this assessment to look for long-term impact. In the meantime, we visited the children weekly during the period of intervention and asked about adherence, as well as infection and clinic attendances or hospitalization. And during the monthly period, and during the long-term follow-up, we visited them monthly and again assessed about infection and clinic attendance and hospitalization. The study was set in the Rupganj area of Bangladesh, which is just outside Dhaka, about 30 kilometers outside Dhaka, and we worked in 3 unions of this sub-district here, in the Rupganj, Bulta, and Golakandal area. So this is what the interventions looked like. So every child on the trial received 2 products, and they were asked to take them both daily. And these were either one or both of these was active. The randomization was undertaken in the field, by pre-assigned allocation lists. A randomization was stratified by sex and union, and there was really no way for anyone to tell what these were. And indeed, you can see that we changed the name of the sprinkles packets to match the trial. So we gave the kids 12.5 milligrams of elemental iron daily, or given with a dropper or placebo. Or we gave the children multiple micronutrient powders, which were the 5 micronutrient formulation with ferrous fumarate at the same dose, 12.5 milligrams, along with vitamin A, vitamin C, folic acid, and zinc, or placebo. So the eligibility criteria, the children were 8 months of age, plus or minus 2 weeks, and they had to have a hemoglobin above 80 grams per litre. This was rare. An HB lower than this was rare in the community. Only about 1.5% had this. They couldn't have an inherited red cell disorder that had already been diagnosed. We all know that Bangladesh has areas where there is elevated groundwater drinking iron. So we tested the drinking water iron for every child on trial, and we excluded them if they had if it was above 1 milligram per litre. They couldn't have a fever or current illness, but they could be re-recruited if they recovered while they were still in the recruitment age window. And they couldn't have a congenital disorder precluding cognitive assessments, and they had to be expected to remain in the trial site. The primary outcome was child cognitive development measured by the Bailey scales of infant and toddler development at the end of 3 months intervention. And then secondary outcomes included child development after 9 months after completion of intervention, and then motor language development, and also behavior and temperament measured by validated scales, both immediately and after 9 months, together with child growth. And then the prevalence of anemia, iron deficiency anemia, both immediately and 3 months and 9 months post the intervention, as well as infection risk, particularly diarrhea and respiratory infection, as well as unplanned clinic visits and hospitalization during the intervention and post-intervention. The primary outcome was measured using the Bailey scales of infant and toddler development, which is considered widely as one of the gold standard series of behavioral assessments used by clinicians and researchers to assess the developmental functioning of young children. It's a long and arduous test to administer. All of our testers had a master's degree in psychology or social sciences. It took about an hour per test, and we did about 8,000 of these tests in the field, in the study office, in various health centres, and even in the homes of some of the families. Prior and during the trial, we continued to assess the reliability and concordance between the testers, and you can see that there was high agreement and reliability between our team of testers, indicating the high quality of the cognitive assessments. So we screened 4,000 children for the trial. We excluded about 500, and about 200 were unwilling to participate. So we randomized on track 3,300 as expected, 1,100 or so to each arm. And by midline at the primary outcome assessment, where we'd expect to lose 20%, we'd only lost 13% or so to the trial. And even by the end line assessment, we'd maintained less than 20% loss to follow-up. Adherence was high. We had about above 85% consumption of the doses on the trial, and about 74% of the kids consumed more than 70% of the doses. At baseline, the prevalence of anemia was 45%, iron deficiency was 28%, and iron deficiency anemia 19%. So this would be the type of place the WHO guidelines to give universal iron interventions would be given. Just to show you briefly that you don't need to read all this data, just to say the three arms were balanced in terms of household characteristics, wealth, the child characteristics, baseline anemia, child growth, baseline iron deficiency, and even baseline child development. Okay, so I'll show you some of the results now. So the first thing I'll show you is just that there was iron in the iron. We saw a striking effect of the intervention on anemia. So you can see that there was a similar effect between the interventions and about a 50% reduction in anemia at the end of intervention. So this is right after the intervention on the left, and even still maintained 9 months after the intervention was completed. So you can see a persisting effect on anemia right out to a year. Likewise, we saw a striking effect on the prevalence of iron deficiency from both interventions that was similar between both iron drops and micronutrient powders right after the intervention. And again, this was maintained right out to 9 months post the end of the intervention at a year post recruitment. Finally, we saw a profound, about 80% reduction in the prevalence of iron deficiency anemia from both interventions that was similar effects between iron drops and micronutrient powders. And again, this was maintained right out to the follow-up period. This means that the kids got the iron got into the systems. And so I think our trial was well set up to understand the effect of iron on the primary outcome of child development. And the answer is that there was no effect from iron interventions on child development. We saw absolutely no effect on child cognitive development at the end of intervention, nor at the end, nor at 9 months post-intervention. And so remember that during this time, these kids had increased iron stores, but we still didn't see an effect on child cognitive development. Likewise, we didn't see an effect on language, either at the end of intervention or post-intervention. And we didn't see an effect on motor development at the end of intervention or 9 months post-intervention. In terms of growth, we did not see a significant effect from either intervention on child growth, and nor did we see an effect on on linear growth either. In terms of the exploratory outcomes of child behavior, so this is the Waltz behavior score, and this is the temperament scale. These could be considered a surrogate for child well-being. We did not see any effects in this placebo-controlled blinded trial of iron or micronutrient powders on any of these outcomes compared with placebo. In terms of safety, we did not see a significant effect from iron on diarrhea, but certainly we did see perhaps a signal of an adverse effect, but there was no difference between the two interventions, and this was not statistically significant. And we did not see any effect on respiratory symptoms during intervention. In terms of serious adverse, in terms of unplanned clinic visits, we did not see an effect on clinic visits from these interventions, and nor did we see an increase in serious adverse events or a protection from serious adverse events from these interventions. Indeed, in terms of study deaths, they were pretty much identical across the groups, and likewise hospitalization and other serious adverse events. In terms of subgroup analysis, we wanted to see whether children who had baseline anemia, iron deficiency or iron deficiency anemia had an effect, had perhaps a different effect on child development, but we did not see an increase in an improvement on child development or a difference in the effect on child development from either iron or MMPs, even if the kids had a baseline iron deficiency anemia, iron deficiency or anemia, even though we did see an increased effect on hemoglobin concentration in children with these baseline deficiencies. So just to summarize, both iron supplements and micronutrient powders reduced anemia and iron deficiency in the immediate and medium term, but there was no benefit from either intervention on functional child health outcomes, cognitive, motor, language development, behavior, well-being, or growth. But the interventions do appear safe, and both interventions actually have very similar effects on anemia and iron stores. This was an efficacy trial, and so we can conclude in this efficacy trial context that iron interventions do not have an effect when delivered as a universal health intervention on developmental or functional outcomes in young children. Now, what is the explanation? It could be that there was no clinical association between iron status and brain development. And this is something that has obviously been witnessed in many observational studies. Maybe that's just residual confounding, or maybe the numerous animal studies are just not relevant to human people, to humans. It could be that treating an iron deficient infant is too late and the impact actually occurs earlier. And in fact, we need to be preventing anemia and iron deficiency in utero. Or it might be that the effect may manifest in the longer term. We need to be following up these kids longer. I do not think that these findings are because the effect size is too small, because our study was powered to a tiny Cohen's d effect size. Nor do I think it's because the outcome assessment is insensitive, because sanity checks on our data indicate that there were appropriate associations with things such as home stimulation and child development. So I think our data have implications for policymakers in selecting anemia control policies around the world, and in terms of the evidence, in terms of selection between interventions, in terms of risk-benefit analysis, and in terms of health economic analysis. And they also have implications for the clinical care of anemia, of anemic iron deficient and iron deficient anemic children. I won't go into this, just to say that this trial is currently being repeated in sub-Saharan Africa to give us another site to understand this. And here we're doing the trial under anti-malarial cover to ensure protection. And we should have data on this in the next 2 years. I'd just like to finish off by thanking the enormous team. I've thanked the Bangladeshi team already, just to thank them again for all their hard work. To thank my lab here in Melbourne and who've helped me and worked tirelessly, particularly Sabine and Layla and Andy Baldy. To thank my colleagues at University of Melbourne, particularly Bev Biggs, and also to thank, of course, the trial participants and their families. Thank you very much.
Thank you very much, Santa. That was a very interesting presentation. We will keep the questions for the end of the 3 presentations. I see that Sarah is back. Sarah is back on now. I've already introduced her. So please go over to you, Sarah. Go ahead. Thank you.
Okay. Hi, everybody. I'm so sorry for the technical glitch there with our internet. So thank you, Angela, and thank you all so much for listening. I think, as Santa has already shared with you, the global burden of anemia in young children is extremely high. And I just want to point out to you that a lot of this anemia is in sub-Saharan Africa. About more than 60% of children living in sub-Saharan Africa are anemic. And in a study of about 5,000 children, using the WHO guidelines, approximately 35% of children were iron deficient. But after adjusting for inflammation and malaria using a Brinda approach, approximately half of children were iron deficient. So what is causing iron deficiency and anemia in these children? Well, there's many factors. Children living in sub-Saharan Africa have a diet that's very low in bioavailable iron. You can see here, this is ugali, which is made of maize flour. Some maize cobs here, which I can tell you are absolutely delicious. And there's also a bit of sukuma wiki here, which is very much like kale, which has a bit of iron, but poorly available. So giving iron is recommended by the WHO, and it's the primary intervention, whether it's supplementation, whether it's micronutrient powders, or food fortification. But I'd like you to engage with me in a little bit of heresy. What if, maybe we can just consider this, what if giving iron is actually not the best intervention? As we've just heard, there's literature showing that iron may not be safe, may increase the risk of malaria, may increase the risk of other infections. It may be poorly absorbed in children with a high burden of infection. And as we've also just heard, it may alter the gut microbiome, making children more susceptible to more pathogenic bacteria. So maybe what we need is a new strategy. So malaria transmission in sub-Saharan Africa is persistent and widespread. The WHO malaria report in 2019 found that in 2018, there were 213 million cases of malaria and approximately 380,000 deaths, with the majority of these concentrated in sub-Saharan Africa. And approximately a quarter of children, although in some places up to 50%, may have malaria parasitemia, just asymptomatic malaria parasitemia at any time. So there's a few studies that suggest that maybe malaria might be increasing the risk of iron deficiency. This is a study in children in the highlands of Kenya, and this is the prevalence of iron deficiency here. And what they did in this study is they treated children between May 2007 and July 2008 with antimalarials, indoor residual spraying, bed nets. And they found that by interrupting malaria transmission, the prevalence of iron deficiency reduced quite substantially. And there's been a couple of other very interesting studies of stable radioisotope studies, both in children and in pregnant and in women. And they found it was 17 children and 23 women. And this was in the 23 women, that when the women had malaria, and this was actually just asymptomatic malaria parasitemia, the absorption of iron was low. But after treatment of malaria, the absorption of iron almost doubled. And at the same time, during the malaria, hepcidin was high, and inflammation was also high. So these studies suggest that perhaps malaria itself could be causing iron deficiency. So in an observational study, we would look at malaria and how it might cause iron deficiency. But there may be a number of confounders, such as nutritional status, socioeconomic situation, age, and there may also be the problem that maybe iron deficiency itself might influence malaria, perhaps there's reverse causality, or maybe it's actually really hard to work out because children with malaria also have an acute phase response and ferritin levels are increased. So you can do a randomized controlled trial, but another approach is to use a genetic proxy for your exposure. So for, in this case, in malaria. And the advantage of this is that it's less susceptible to all the confounders, and reverse causality will not happen. So the first assumption is that the genetic variant must strongly and specifically be a proxy for the exposure. That's our number one assumption. The second assumption is that the confounders that might influence the observational relationship should not affect the genetic variant. And if we just remember here, the genetic variant is randomized at conception. So it shouldn't be subject to these potential environmental confounders. And the third assumption of this is that the genetic variant should act only through the exposure. So in this case, our genetic variant should only be working through malaria. And it shouldn't be affecting iron deficiency through an alternative pathway. So the basic idea is that if malaria is causing iron deficiency, then a genetic variant that protects children from malaria should also protect them from iron deficiency. And this is called Mendelian randomization. So let's look at our first assumption. We looked for genetic variants that could be instrumental variables for the exposure for malaria. And the first one we looked at was sickle cell trait. So we did a meta-analysis of the available literature, and we're here looking at uncomplicated malaria, which is what children get very often in sub-Saharan Africa, perhaps a few times a year. And we found in our meta-analysis that sickle cell trait gives about 30% protection against uncomplicated malaria. It gives about 82% protection against severe malaria, but we were less interested in that because it's unlikely at a population level to be causing iron deficiency. We also looked at G6PD and alpha thalassemia, but could not find reliable evidence that they influence the risk of uncomplicated malaria. Okay, so we've shown our assumption 1. So then we need to look at whether sickle cell trait influences the risk of iron deficiency in populations that are exposed to malaria. And we also need to check that it's not working through a separate pathway in populations that are not exposed to malaria. So we had 10 study sites in collaboration with many people across sub-Saharan Africa, East, West, and Central Sub-Saharan Africa, and a total of about 7,450 children. For individuals without malaria, who have never been exposed to malaria, we had African Americans who had never seen malaria, and also children who were lifelong residents, certified to be lifelong residents, and who had not traveled outside Nairobi in Kenya, where there's no malaria transmission. So in these children, we looked at iron status in relation to sickle cell trait. So these are our findings. We found that sickle cell trait protects against iron deficiency among children living in sub-Saharan Africa in malaria endemic areas. And this protection in meta-analyses was about 30%. So then we also looked at whether sickle cell trait protects from iron deficiency in populations that are not exposed to malaria, and found that there was no effect of sickle cell trait on iron deficiency in these populations. We further repeated our analyses using pooled data, also using adjustment for malaria and inflammation in Brinda regression analyses, and found the same results. We also found similarly that sickle cell trait protects against iron deficiency anemia. And this was a similar level of protection, about 31% reduction in the risk of iron deficiency. And again, there was no effect in populations that are not exposed to malaria. So if malaria causes iron deficiency, then we would expect that a genetic variant, as in our case, sickle cell trait, that protects children from malaria will also protect them from iron deficiency. And that's what we found. And no effect in populations that were not exposed to malaria. But what about these confounders? We need to think about our second assumption here. So we also looked at whether any of these factors that might confound could be associated with sickle cell trait. So we found that there was no association between age and sickle cell trait, no association with sex, or with nutritional status. So children with sickle cell trait were not more or less underweight. But we did find an association with inflammation, that children with sickle cell trait, these are children living in sub-Saharan Africa, have a 25% reduction in their risk of inflammation. So we initially scratched our heads a bit and then thought to ourselves, well, perhaps inflammation is actually on the pathway between malaria and iron deficiency, and maybe this could explain it. So we looked at the prevalence of inflammation by sickle cell trait in children from malaria endemic sites, and then also in individuals in non-malaria sites. So in children exposed to malaria, inflammation was lower compared to those without sickle cell trait, but there was no difference in the effect of sickle cell trait on inflammation in individuals not exposed to malaria. So it is well known that inflammation increases hepcidin and is an iron hormone that blocks iron absorption through degrading ferroportin. So we looked at hepcidin levels in approximately half of our children from sites in sub-Saharan Africa. And inflammation was very common in these children. So 15% of children had inflammation in the Gambia, and this went up to 68% in children living in the DRC. So we saw that this is the hepcidin level here, and this level of 5.5 has previously been shown to impair iron absorption. So in children with no malaria and no inflammation, iron is being absorbed. In children with no inflammation, but they do have asymptomatic parasitemia, the hepcidin level is above a level that might be expected to reduce iron absorption. And children with inflammation had the highest hepcidin levels above a level that reduces iron absorption. And in children with both inflammation and malaria, the hepcidin levels were the highest. And I would point out that sickle cell trait would protect against malaria with inflammation, against clinical malaria, but there's no evidence that sickle cell trait protects against asymptomatic malaria. So we propose that malaria may be causing iron deficiency through a hepcidin-mediated block in iron absorption. And looking at the hepcidin levels, hepcidin here on the y-axis and CRP decile on the x-axis, looking at that level of 5.5, the blue line here are the deciles of CRP. And we can see that about the 6th decile of CRP, iron absorption starts to be impaired. The brown line is children who also have malaria. And at almost every decile of CRP, hepcidin levels are higher in the children with malaria. So finally, in Mendelian randomization analyses, we found that genetically predicted malaria risk is associated with a 2.65-fold increase in iron deficiency per unit increase in log incidence rate of malaria. In further analyses, this suggests that an intervention that halves malaria incidence would also reduce iron deficiency by 49%. So, our data suggests that if we halve malaria incidence or we reduce malaria substantially, we may be able to control a large proportion of iron deficiency in sub-Saharan Africa, about 49%. If we give iron, there's a risk of malaria, risk of infections, maybe poorly absorbed, there may be problems with the gut. If we treat malaria, it will allow iron to be absorbed. And perhaps we might just kill 2 birds with 1 stone. So I'd like to finish by saying that perhaps if we reduce and treat malaria, it would allow these children to absorb dietary iron. So perhaps they'll be able to absorb that iron from their sukuma wiki. And I'd like to recommend that strategies to treat and prevent malaria and other infections should be an integral part of programs to reduce iron deficiency in Africa. And I'd like to say thank you so much to so many people who've been very generous in sharing samples, data, expertise. And I'd especially like to thank John, who did this work as part of his PhD thesis. And yes, so many people to thank, and thank you so much for listening. Thanks.
Thank you very much, Sarah. That is very interesting and new ideas for policymakers to consider. In the absence of Dr. Webb, who has not been able to join us due to some other issues, we will get on to the question and answer sessions now. There are lots of questions that have been sent in by the audience, and I will start with a couple of questions to Santa, and followed by a couple of questions to Sarah. So Santa, one of the questions is, why did you enroll the children at 8 months and not from 6 months, since the intervention only lasted 3 months? Could that be the reason why you have not seen cognitive functions and growth effects of iron supplementation?
Yeah, we chose, we actually initially planned to go in at 9 months, to go in with the measles vaccine time point. And the reason we actually went in with 8 months was a strategic error on my behalf when planning the study, which is, of course, if you give a whole trial the measles vaccine, then a couple of days later take their blood to look for the baseline prevalence of iron deficiency, you've just induced inflammation in your entire study population. So that's why it was a funny time, which was 8 months. It was meant to be 9 months, but that's the reason it was that funny time point. I'm not convinced that we would have seen any difference in this result if this study had occurred at 6 months or 8 months. I think the prevalence, most longitudinal data sets would suggest that the prevalence of anemia and iron deficiency is ramping up over that second 6 months of life. So we are in the sort of steep uptick time when the prevalence of anemia is increasing. Indeed, the prevalence of anemia in the placebo group was actually higher again at 11 months than it was at recruitment. So I think we had a period of time when the prevalence of anemia was high and was getting higher and was higher than it would have been at 6 months.
Okay, thank you. So do you think that fundamentally the importance of iron in brain development has been overstated? Is it possibly the effect of anemia that you see, or what do you think?
Yeah, I've been reflecting a lot on our details, on our data, and I must say, so the trial was only unblinded about 8 weeks ago, so we are still, when you unblind a trial, you spend most of your time wondering what's going on. I think for us, I think the experimental data in animals are pretty convincing that iron is critical to neuronal development in the hippocampus. It's critical for myelination, for neurotransmission, but animal models are not humans. They have extreme phenotypes. Often they've got genetic mutations deliberately to allow manipulation of iron status or whatever you're looking for. So I think that it's never the right idea to say that a rat or a mouse is now clinical data for humans. So I think what we're providing is clinical data. I think that one important possibility that remains is that the effect is prenatal or even younger. So one of the questioners asked 6 months, but I'd say that the question remains open another 9 months before that, which is, in the second or third trimester, that an antenatal anemia is thought to have some profound effects on neuronal iron brain development in the fetus. But I think we can only be led by the data we have. And I think that we've got the efficacy data now to be fairly confident that at least in this South Asian setting, there isn't an effect on child development to the best of 8,000 Bailey's tests later.
Thank you. Two more questions really. One is, so you think that the importance of setting a global anemia target on women of reproductive age is the correct thing to do, considering that iron deficiency may have effects in earlier life than in later life, possibly.
Yeah, I think the time is coming where we need to redefine what we understand by the syndrome of anemia. Just as we've probably been revisiting what we mean by the syndrome of stunting and so forth over the last few years. So, Sarah's just presented very compelling evidence of the direct role of inflammation, probably in this case due to malaria, on impairing iron absorption and resulting in iron deficiency and anemia. And so it really indicates that that anemia is an endpoint of a broad range of syndromes. And I think that when a population improves in terms of their well-being, their hygiene, their nutrition, a whole complex set of factors occur, and you see the anemia prevalence reduce. And I don't think it's quite as and I think that we need to be mindful of what we're actually trying to achieve by that improvement in anemia. I think one very clear result of our data is iron and MMPs destroy the prevalence of anemia. It does go down by 50%. Iron deficiency anemia is eradicated. We just couldn't find what that means, what benefit we're getting for the kid on that outcome.
That's very interesting. There's one more comment saying that 75% of your sample was iron sufficient. So could the potential adverse effects of iron be due to iron provision in this group have led to these null functional effects overall? Is that a possibility in your analysis?
No, so on a subgroup analysis, so we did subgroup analyses for all the outcomes that I showed you. I only showed you the cognitive, but on the subgroup analysis for iron deficiency, there was no advantage. There was no improvement in child development in that subgroup analysis. And that subgroup analysis is still larger than most, or I'd say almost any other clinical trial on effects of iron on child development in iron deficient. I think it's probably the biggest trial in iron deficient children because it's still about 300 children per arm who are iron deficient, and about 200 children per arm who are iron deficient anemic randomized to iron versus placebo. And we still didn't really see an effect or a signal in those subgroups.
Okay. Thank you very much, Santa. I will switch to Sarah now for a couple of questions, and then maybe if there are more questions, we will take them. So Sarah, thank you very much for your presentation. And the Mendelian randomization approach is innovative. There's a question that holding off iron for 4 weeks and treating malaria alone would improve hemoglobin by itself. Would you also recommend holding off iron in newly diagnosed cases of anemia who also have uncomplicated malaria? Would this also hold for severe anemia? So that's a couple of questions in one.
Sorry, Angela, could I just have the first part of the question again?
Okay, so would you recommend that holding off iron treatment and treating malaria alone? There are some studies which have showed that this has improved hemoglobin. Would you also recommend holding off iron in newly diagnosed cases of anemia who have uncomplicated malaria? And also, would this hold for cases of severe anemia?
Okay, so I think when children have malaria, as we've seen and has been seen in the literature, their hepcidin levels go quite high. Especially we've seen that hepcidin levels are highest in children with severe malaria, and then somewhere in between with the uncomplicated malaria, and then lowest with the asymptomatic malaria. So I would say if a child has malaria, they're probably not going to absorb the iron that you're giving them, which could cause gut effects if the iron is just in the gut and not being absorbed. So, whether it would hurt or not, I don't know, but it may not be very efficacious to give iron during malaria infection. And I think I would recommend treating the malaria and then giving iron so that it can be absorbed.
Thank you. Yeah. So what we will do now is Dr. Whip is online. So we will stop the question and answer session. I'm sorry. And we will get on to Dr. Vip's presentation and then come back for a quick final Q&A session before we end this session completely. So if I may introduce Dr. Vip to all of you. Dr. Vip is the Professor of Pediatrics and Research Program Director at the Division of Pediatric Hematology and Oncology, Department of Pediatrics, Thalassemia Center, Faculty of Medicine, Siraj Hospital at Bengal University. Dr. Vip has done extensive work on thalassemia, including its molecular
มันมีสอง
basis,
อันอันไหนอะจ๊ะอันซ้ายใช่ไหม
correlation,
อัน
and
นี้เนาะ
iron invasive prenatal
ใช่ไหม
screening.
อันนี้เนาะ
He has
อันนี้เหรอ
researched clinical management and development in clinical and laboratory tools for iron overload and iron deficiency. Today, Professor Vip will share his experience and expertise on the biology of anemia, including overview of hemoglobinopathies. Over to you, Professor Vip.
Thank you very, very much, Angela. And first of all, I would like to apologize for a delay or and joining you guys because of I have an emergency patient and I just finished dealing with the case. And I'd like to thank and say hi to everyone. Important aspect related to the hemoglobinopathies and anemia, especially related to the our clinical experience in the forest. Can you hear me properly, guys? Hello. Oh, okay. So I go ahead. Okay. Okay. Yes. So just start with the anemia. I'm a hematologist by training. So it is very important that, we produce red blood cell from the hematopoietic stem cell in the bone marrow, and later on change into committed myeloid progenitor cell and further develop into the BFUE and CFUE, and is undergone the final erythroid differentiation step from the pro-erythroblast to basophilic erythroblast to polychromatophilic erythroblast, autochromatic, and into the reticulocytes and the red blood cell. Reticulocytes seem to be a very important marker to reflect the bone marrow activities. And from the CFUE into the pro-erythroblast and terminal erythroid differentiation. I'm sorry. ทำไมมันวิดีโอมันไม่ขึ้น That's okay. It's under control of erythropoietin, and abnormality in the production or the hemolysis has the different effect on the red blood cell and of course the number of reticulocytes that I will later mention. So I just want to start with a case study. So this is one of the patient, 15-month-old boy who came to our clinic because he has been noticed with the pallor on his lip, as you can see on this picture. He has hemoglobin of 6.5, hematocrit of 19, and the red blood cell of 2.5 million. And the red blood cell MCV, MCH, MCHC, all of these red cell indices, which is normally we perform by the complete blood count as shown you on the slide, and the RDW also show a little bit increase in terms of the red cell distribution width. The white blood count seems to be normal with the platelet has the thrombocytosis. So the definition of anemia that we use as a pediatrician and hematologist, we use the criteria by WHO or the CDC, as I show you on this slide. In terms of the definition, we define anemia as the hemoglobin below the 5 percentile of the healthy population. And most of the studies show the cutoff, which is beyond 2 SD from the mean of that age. So if we go back to this boy, which is under 2 years of age, and he has hemoglobin lower than 10 grams per deciliter based on the CDC guideline, so I can say he has anemia. So we come back to this parameter, you can see that he has hypochromic microcytic anemia because of the MCV is low, the MCH is low, and the platelet is increased. We perform reticulocytes, which is one of a very common evaluation when we got children with anemia, and the reticulocytes show 0.5%. So as a simple approach to anemia, we're looking at the number of reticulocyte count, which is normally is around 2 to 3%. So in this boy, he got a decrease of the reticulocytes, suggesting that he has lower production from the bone marrow, which can be caused by the nutritional anemia, iron deficiency anemia, or he might have some bone marrow diseases. It seems to be rare or very uncommon compared to the first two courses. The bone marrow diseases that we have in children, including the congenital dyserythropoietic anemia, Fanconi anemia, or even aplastic anemia. Last but not least, also found in children who have the chronic renal failure. It's not a very common condition. If the reticulocyte count increase, we have to think about the caused by the hemolysis, and the reticulocytosis is a compensatory mechanism that our body used to compensate with the red cell that have been destroyed. So in the hemolysis, we have to think about, our autoimmune hemolytic anemia, which is not a very common cause in children. More commonly is inherited anemia. And there are three major forms of the inherited anemia that I'm going into detail later on. And finally, in the early state of the blood loss, you have the reticulocytes as compensation increase. But if you have a chronic blood loss, you leading to the iron deficiency anemia, and the reticulocyte count will be decreased. So in this boy, because of reticulocytes is 0.5, we think about, the iron deficiency anemia. This is another schematic diagram to show you a approach that we can do, and I adopt this from the ASH, American Society of Hematology education book. So if you have a patient who has increased reticulocytes, you think about hemolysis, and we're looking for some evidence of hemolysis. And if the reticulocyte is low, as this boy, you have to look at the causes, including the iron deficiency anemia and the nutritional anemia, including the folate deficiency or cobalamin deficiency. In his blood smear, as you can see, this is a hypochromic microcytic blood smear, and you see a lot of the platelet, which is one of the common finding in those who have the iron deficiency anemia because of the thrombocytosis. You can see some of the pencil cell, which is in the middle of the slide, and also you don't see the reticulocytes or polychromasia. So this is a very typical blood picture of those who have iron deficiency anemia. Besides using the reticulocytes, we can also approach it by looking at the size of the red blood cell as well, whether the red blood cell is lower in terms of the mean corpuscular volume, or it has a normal corpuscular volume, or it has an increased mean corpuscular volume. For the higher MCV, usually identified in nutritional anemia with the macrocytosis, such as the vitamin B12 deficiency or the folate deficiency. For the normochromic normocytic anemia, usually related to the blood loss and some of the hemolytic anemia. But more commonly, especially in my country, in my region, is the microcytic anemia. And this microcytic anemia, you have to think about two different important causes. One is thalassemia, and another one is the iron deficiency anemia. So we come back to the boy, and after 3 months of the iron supplementation, he has increased level of the hemoglobin and also increased level of the hematocrit. The red blood cell count increased from 2.5 million up to 5.5 million. However, and of course, we correct the RDW, which is representing the anisocytosis, into the normal range from the 19, and the platelet count, which is have relatively thrombocytosis, is now go back to the normal range. However, his MCV and MCH remain under the normal range, so he still have microcytosis and hypochromic red blood cell. And when you look at the blood smear, this is the blood smear that in this boy you can still see some of the hypochromic cell. So what will you do next? In the country, in the tropical country, and country which has a very high endemic of thalassemia and hemoglobinopathies, the next thing you have to do is to evaluate for hemoglobinopathies, because for example, in this boy, he doesn't really have any more of the iron deficiency anemia. We measure the level of the serum ferritin, and the transferrin saturation is back into the normal range. So when we use the hemoglobin analysis, you can see the hemoglobin E using the chromatography in the E window of around 30%. And more importantly, we have to recheck for the alpha thalassemia as well. And he has the alpha plus thalassemia carrier. So he is the double heterozygous for thalassemia, both alpha thalassemia and the beta thalassemia, which is the hemoglobin E. I have a chance to look in my 150 Thai children who has been diagnosed with the iron deficiency anemia. And we evaluate for the globin abnormality thoroughly, and we have identified that 62% of them have only isolated iron deficiency anemia. They don't have the thalassemia. So if you're looking at the bar graph in the lower panel, comparing between male and female, so you can see a typical picture of the natural history of iron deficiency anemia. Usually there are two peaks. One in the early childhood during the toddler, when we switch from solely breastfeeding into the supplement food, and they don't have enough iron enriched in their daily feeding. So you can see, the incident is more on male than the female. Maybe, male baby are more fussy than female on eating. And more importantly, if you see another peak at the 12 to 14 years of age, and that's more common in a young female teenager, because of they start to have menstruation. So this is a classic a picture of the iron deficiency anemia. However, if you look at the upper panel for those of the children who have the iron deficiency anemia with thalassemia, so you can find them, at any age. And also, I would say, having thalassemia may exemplify the phenotype of the iron deficiency anemia that make them, become visible or require for the medical evaluation and intervention. So if the reticulocytes is increased, normally after you supplement them with the iron and they have the iron status normal, that especially in those who have the thalassemia carrier. But for those who have the thalassemia disease, they will have definitely have increased reticulocytes. Increased reticular size besides thalassemia, it can caused by some other common inherited red blood cell abnormalities, including the red cell membranopathies and the red blood cell enzymopathies. All of these inherited hemolytic anemia has the common feature, including anemia, jaundice because of the hyperbilirubinemia, they leading to the gallstone formation early in their childhood. Like today, I got two a patient. One is only 7 years old, another one is 8 years old, who have the gallstone developed already in their gallbladder. They have the splenomegaly, and some of them have hepatomegaly. And of course, because of the chronic anemia, you have increased absorption of intestinal iron through the hepcidin and ferroportin dysregulation, and they will ending up having the iron overload. Normally, we're looking at the red blood cell morphology to highlight and point out the cause of the hemolytic anemia. And I just show you some of the typical blood picture that we have found very frequently in our clinic, including the red blood cell membranopathy, such as the elliptocytosis, spherocytosis, and pyropoikilocytosis. For the hemoglobin disorder, including thalassemia, you're looking for something which is a hypochromic microcytic anemia. But if you remember the picture of the typical IDA earlier that I showed you, the picture of the hypochromic microcytic in both conditions has some different feature. For thalassemia, you see a lot of red cell with the this morphology, schistocytes, and also fragmented red blood cell. And you can see in the thalassemia disease, they have polychromasia and the nucleated red blood cell, which is, you don't see it in iron deficiency anemia. For red cell enzymopathies, you're looking for something which we call the non-spherocytic hemolytic anemia. Red blood cell become fragmented, and some of them is look like, or it had been cut by knife or by a piano string. We have the cohort of nearly 2,000 children with hemolytic anemia. And of course, majority of them, 1,500, are thalassemia disease, including the alpha thalassemia and the beta thalassemia, and followed by the red cell membranopathies and red cell enzymopathies. For the membranopathies, the number one in our clinic now is the is the elliptocytosis, and caused by the spectrin beta mutation. For the enzymopathies, we have majority of the G6PD deficiency and followed by the pyruvate kinase deficiency. So if focused on the globin abnormalities, the globin is a very important component within the hemoglobin molecule. So when you have the absence or reduction of the synthesis of the beta globin chain, we call the beta thalassemia, and vice versa for the alpha chain, we call the alpha thalassemia. And that leads to hypochromic microcytic anemia. So most of the thalassemia mutation caused by the coding sequences mutation, either in the alpha or the beta globin gene, and less commonly by the trans mutation. So the alpha and the beta are located on the two different chromosomes. So one can have more than one globin mutation, especially those in Southeast Asia. So this picture show you the structure and the expression, so make you understand more on the hemoglobinopathies. Alpha globin cluster located on chromosome 16, and the beta globin cluster is located on chromosome 11. So during erythropoiesis in embryo, we produce the theta and the epsilon, and we change to the fetal hemoglobin, which is the alpha and the gamma, and the adult is the alpha and the beta. So the beta globin is controlled by the locus control region upstream and also for the alpha globin cluster as well. Mutation on the globin gene itself, especially for the alpha, is mainly the deletion, and the beta is mainly the point mutation, leading to the decreased expression or completely absent, and that the underlying causes of thalassemia. Less commonly is caused by the deletion that remove the regulatory element. Globin abnormalities for the alpha and the beta are widely spread throughout the subtropical and the tropical region of the world. In Africa region, in Indian subcontinent, and also in Southeast Asia. So this picture shows you a different color representing on the left-hand panel is the beta globin mutation, which include the hemoglobin S, hemoglobin C, hemoglobin E, and the beta mutation. For the alpha, represent on the right panel, right upper panel, which is the blue and the navy blue. And the lower panel show you the endemic of the Morelia, and you can see that this area is overlapping of the thalassemia and the Morelia, because thalassemia and hemoglobinopathies has the selective advantage against Morelia infection in history. In Southeast Asia as well, all of these countries, including Thailand, we have such a very high frequency of thalassemia and hemoglobinopathies carrier. In my recent study, which is published last year in eLife, the alpha thalassemia is up to 49% of our population. So like nearly half of Thai people have thalassemia gene. Interaction of thalassemia gene and hemoglobinopathy genes interact and give rise to two different important spectrum. Now we call as the transfusion-dependent thalassemia and non-transfusion-dependent thalassemia, TDT and NTDT. For the beta mutation, we have different point mutation. For example, like in our study in 2010, we have nearly around 200 different mutations in Thailand and over 1,500 different mutations that have been reported in the beta globin gene. And you can see the detail in the globin gene server and the ClinVar. Interaction of the beta mutation resulting in the most serious condition we call beta tau major. If we don't treat them, they will become full-blown thalassemic picture, anemia, hepatosplenomegaly, bony fracture, growth retardation, and have iron overload. Because of this anemia, leading to several complications in their life, you can see a very remarkable bony changes, jaundice, gallstone, and hyperplasia of the liver and the spleen. For the hemoglobin E interact with the beta thalassemia, causing another very important syndrome, especially in Southeast Asia, we call hemoglobin E beta thalassemia. These have been first reported long time ago in Thailand by my predecessor, Professor Nanakorn and Professor Tujinda in 2054. The most interesting feature of this hemoglobin E beta thalassemia is the clinical phenotype. They can have a very wide range of the severity from a very severe as NTDT into the less severe as the NTDT not require regular blood transfusion to a very severe phenotype as TDT similar to beta tau major. For the alpha thalassemia, I have several reviews that might be of your interest. And mainly the alpha thalassemia caused by the deletion that remove the alpha globin gene itself. We have two linked alpha globin gene per one chromosome. So the most common alpha zero thalassemia in Southeast Asia. Yes, okay, I'm finishing. Is the alpha zero thalassemia by deletion of the alpha globin gene. And interaction of alpha thalassemia resulting in hemoglobin H disease and hemoglobin bath hydrop if you completely remove the alpha globin gene itself. And this is the picture of the red cell in alpha thalassemia and the feature that we use the hemoglobin analysis. The clinical spectrum in alpha thalassemia also wide variety. On your right-hand side is the transfusion-dependent or hydrop, which die in utero. And on the left-hand side, the patient can be asymptomatic and never require blood transfusion. So now you can find a recommendation for the guideline to the Thalassemia International Federation and one of the editorial team that help. So in summary, the biology of the anemia is directly related to decreased red blood cell production, blood loss, or hemolysis, which leading to the red cell destruction. Using simple algorithm, we can suggest different pathology causing anemia. It is not uncommon to find more than one pathology leading to anemia, especially in the tropical world, as I show you in the example patient, and it's very common. Nearly 40% of our anemic child has more than one cause, especially IDA and thalassemia. And finally, thalassemia and hemoglobinopathies are the most common cause of the inherited anemia and should be always evaluated in those from the endemic region, as I showed you earlier. Thank you very much for your attention.
Thank you very much, Professor Vip, for this very interesting overview of thalassemia and anemia. I would like to ask all three presenters to be ready for just a very few. We have just 10 minutes left for a couple of questions. So I would ask the first question. I would like to ask Professor Vic the first question. In the case of the Asia region where you show, and also we have a lot of evidence that there's a high level of thalassemia, either overt or just the trait. What would your policy recommendation be in terms of the regular programmatic iron supplementation that is usually on?
Thank you very, very much. I think that's a very important question. We are about to publish another study. We are dealing with the editor now regarding your question. Because in country like Thailand, which is we follow WHO recommendation of the universal iron supplementation for children. Okay, a lot of our colleague pediatrician they kind of reluctant to adopt this universal iron supplementation with several reasons. And I mean in Africa you have the different aspect of infection and so on, but in country like Thailand and also in Southeast Asia, which we have such a very high prevalence of thalassemia, a lot of clinicians afraid that the patient with thalassemia may already have the iron overload. So giving the iron might be do harm, more harm than help in these children. So that's why we have a study to look very carefully about the iron supplementation in those with the thalassemia and thalassemia carrier. And what we conclude from our study is that even though, especially in a very early age, below 3 years of age, this is the population that we study because this is the recommended age group for supplementation. We don't see any harm if we provide the iron supplementation as a universal policy, because even those with homozygous hemoglobin E interaction of hemoglobin H disease, they still have iron deficiency anemia. So the iron supplementation would not cause any iron overload at all in this age group, even though they have thalassemia. The exemption, the only exception would be those who have beta tau major and beta tau hemoglobin E who are more toward the TDT phenotype. However, those cases, they already presented themselves to hematologists, and we already make the diagnosis because of their anemia is they are not a normal baby. So I don't really think that we will do any harm to this program.
Thank you very much, Vic.
Okay, you're
Thank
very
you.
welcome, Angela.
My next question is to Sarah. Sorry, Sarah, your session was interrupted and we had to break your question session. When you speak about malaria and the studies that you did, are you referring to falciparum malaria, Vivax, or a mix of both?
Thank you, Angela. We particularly looked at uncomplicated malaria, so just malaria. We weren't really interested in severe malaria in the study because severe malaria is a fairly rare outcome, and therefore few children will have it, so it'll be unlikely to influence the risk of iron deficiency at a population level. Obviously, at an individual level, it may well do, but at a population level, it's a fairly rare outcome. So we particularly looked at uncomplicated malaria. So febrile malaria that children would get and perhaps be treated in a clinic.
Thank you very much. So we have just 5 minutes left of our session. And what I would like to do is to invite all 3 speakers to just give one key takeaway message from your studies and your new research findings that you presented, which would be useful to this audience to take research forward, consider policy discussions, and so on. Shall we start with Santa?
To put you on the spot, Angela. Okay, so I think what our data convincingly show is that universal iron interventions, when both iron supplements and micronutrients, MNPs, do reduce the prevalence of anemia in a very effectively. And it seems reasonably safe. Our study was placebo-controlled, so the outcome data is not susceptible to bias there. However, we don't see any evidence of a functional clinical benefit on these outcomes. And that is analogous to the condition in adult women. We know that a fatigued, tired adult woman who comes to see you in clinic, you should treat her with iron. If she's iron deficient, you should treat her with iron. She'll feel better. But we do know that if you just go around and give people who don't feel tired iron, studies have shown there is no benefit in their fatigue scores. And I think what we're seeing is the analogous situation. So I'm not saying, for example, that an iron deficient kid who's not feeding, who's not well, that we should now deprive them of iron. If they're not, we should treat that child. But at the population level, we can't see that benefit.
Thank you. Sarah?
Okay, thank you, Angela. So I would say for children in sub-Saharan Africa, malaria and other infections must be considered as a cause of iron deficiency and anemia, and that we should consider interventions to treat malaria and other infections as a way of controlling iron deficiency and anemia. That's not to say not to give iron, but perhaps if we controlled the infection, the malaria and the other infections, then perhaps, far fewer of the children would be iron deficient and would need iron supplementation.
Thank you.
Thank you.
Vic?
Yes, thank you very much, Angela. I think that I have 2 points to make. The first point would be, in the region, especially in Southeast Asia, in Indian subcontinent, and in the Middle East, and also Mediterranean country, which you have such a very significant prevalence of thalassemia and hemoglobinopathies. When you perform the program for the iron supplementation, and now it's become increasingly practiced, especially in my country, you have to think about these 2 conditions together, IDA and thalassemia. And if you starting to provide the iron supplementation either for the treatment or the prevention, and you remain, still seeing the hypochromic microcytosis, you have to think about thalassemia straight away and don't wait for so long to do a further evaluation for that. The second point that I want to make is that the program, which is as a national policy, especially in young children, I don't see any harm if we want to do that. We don't gain the iron overload as a lot of clinicians afraid of when it comes to thalassemia. They can have the iron deficiency anemia. And as I showed you earlier, that because of these 2 combinations, sometimes they presented, easier to clinician to detect the anemia in children who has both conditions together. So I think this is the point that I want to conclude. Thank you.
Okay. Thank you very much. We've now come to the end of this session. And I would just very briefly, since the 3 presenters gave very important takeaway messages, I would like to first apologize for the mix-up of the presentations and so on. That was due to some technical glitches. But we've been reminded that no doubt anemia and iron deficiency are very, very complex issues, and we don't have answers to many of the pieces of this puzzle. But however, one key message that I could give, as mentioned by some of the presenters, there's a lot of compelling new evidence, and we need to revisit anemia, how we treat it, look at the functional outcomes, look at our public health programs, and so on. Because obviously it looks like one size does not fit all. And we need to have much more research and evidence which would take this this kind of information to a higher level or a better level where we can actually make policy decisions that would benefit all people who have anemia. So with that, I would like to thank all our speakers and Saskia, who was helping in the background. And I would wish all our audience also a very pleasant evening, and thank you very much for listening. Thank you.
Thank you. Thank you. สวัสดีครับ สวัสดีครับ
Thank you.
Yes.
Thank you.
Have a COVID free, everyone. Thank you. Bye.